Over to you, Amrapali ma'am.
Good afternoon, everyone. Today, we stand together to celebrate International Women's Day. This is a day to acknowledge the extraordinary strength, resilience, and the contributions of women across our fraternity. Of course, history is evident that women have faced countless obstacles, yet they have consistently risen above them. They have broken all barriers in every
Madam, you are hello.
Yes.
Yeah,
Can you hear
continue.
me?
Yeah, it was
Yeah.
cutting between some.
All right. Today, we honor the women who dared to dream, who fought for their rights, and who paved the way for future generations. We celebrate our friends and colleagues who inspire us with their achievements and passion towards their field. I welcome our faculties for today, Dr. Josna, Dr. Krupa, Dr. Vani, Dr. Anju, Dr. Suneta, and Dr. Shweta, who are an embodiment of success and thereby an inspiration to our younger generation. Thank you for accepting our invitation for the webinar. I also welcome today's audience. And without further delay, we shall begin our program. Dr. Prashant, let us introduce our first speaker, Dr. Krupa.
Yes, good evening all.
Dr. Prashant?
So,
Yes.
yeah, am I audible? Yes. So, welcome you all
Yes.
in this unique webinar. Dr. Krupa Sankhe is having more than 6 year experience in the field of ENT and vertigo. She is past her MBA, DNB from Government College of New Delhi, and she has pursued her fellowship and vertigo balance with Dr. Srinivas Dosala in Bangalore. After that, she has also worked in many hospitals in like JJ, Nair, Cooper, BDPA. And currently she is working as a chief consultant at Pure ENT Vertigo Specialty Center in Borivali and following her passion. She has trained over more than 1,000 people in the field of vertigo and balance. And she is a key mentor for assessment of management of vertigo and balance disorder in the course which is held in Bangalore. So let us welcome Krupa and have her expert opinion in this field. Krupa, hand over to you.
Very good evening to all. Thank you, Prashant sir, for that kind invitation. And at the outset, I would like to thank AOI Mumbai for inviting me on this very special day. Of course, a special mention of Dr. Amrapali Pawar ma'am and Sun Pharma. And without wasting any further time, on this Women's Day, I would like to start my presentation. So just let me know if my screen is visible.
Yes.
Yeah, it is there.
Okay, I'm sort of making it full screen. Yes. Yeah, so I hope
Okay.
it's visible.
Absolutely.
Okay. Yes. So, oh, I'm not able to take the slides ahead. Okay. So without wasting any further time, I would like to start my presentation today on interesting vertigo scenarios that we come across in an ENT clinic. That brings me to case number 1, which was a 76-year-old female who came to us with case of she was a case of true rotatory vertigo, especially while turning her head in bed and looking up and down. Now, this seemed on history like a classic case of BPPV. All right. She had no migraine triggers as such, and because she was 76-year-old, I inquired about the vascular risk factors, which were negative in her. After completing the ENT and otoneurological examination, which was comprising a Dixall-Pike maneuver, which was negative, a diagnostic maneuver, which was negative. But this patient, let me tell you, kept complaining, no doctor, I'm sure there is a vertigo whenever I turn my head and look up and down. She had such strong history that I repeated the maneuver once again, diagnostic maneuver once again in the clinic. Again, nothing. And I'm sure many of us have come across this scenario who are doing diagnostic maneuvers routinely in their practice. many times patient complains and it seems across while we take the history like a classic case of positional or a BPPV, but it's not the case. So I thought maybe she's one of them, and I was ready to give her, let's say, some therapy and ask her to visit again. But then something made me stop. And I told her, okay, wait, let me complete this patient and I'll call you back again. So after 1 hour, I tried a diagnostic. In the meanwhile, patient was also very cooperative and she said, okay, I want to get this sorted, do whatever you want, but cure me. I said, all right. So when we repeated the maneuver for a third time, again, there is the same glitch. I'm so sorry. Yeah, yes. So this was what was there. All right. So you classically see an upbeating and a torsional nystagmus, which is beating to the left. And the upper pole here, as you can see, is beating to the left, which according to the Barney Society criteria, it was a left posterior canal, BPPV. Of course, you can do this clinically also, but then as you already heard that twice it was coming negative. So I didn't want to miss any finding which might come up because we were also putting a lot of effort from both the ends. So this is how it looks on a VNG. You can see the upbeating nystagmus, and here that is there, and here you can see a reversal also, which is a hallmark of a BPPV. So what we learned from this case is always repeat a maneuver. Yes, I know everybody is busy, but then if there is an occasional patient like this who gives a very strong history and if the diagnosis is in doubt, do not hesitate or be in a hurry to just write some vestibular suppressants like Vortin, Stemetil and send off the patient, or rather do not say that, okay, you have nothing or something like that. So please go ahead and take the patient's history very seriously. Yes, always perform a check maneuver at the end to ensure credibility of your therapeutic maneuver. She was given a left Ipli and she resolved. So just brushing up the basics, especially for the PGs who might be attending this webinar. This is how you can see a very faint left beating nystagmus in light. And when the patient is put in dark, that is how the intensity of the nystagmus increases. I hope everybody is able to clearly make out. High frequency head shake. This is something, as you can already see, there's a left beating nystagmus. Let's see what happens when a head shake was performed. So definitely the intensity has increased, and this was a case of Meniere's. So this is rather vestibular Meniere's migraine spectrum. Now these are the cases who are coming to me because I also do ENT practice. So these are the cases who are visited in the ENT clinic, not in the vertigo days. All right. Moving on to the next case, who was a 64-year-old lady. Known case of vestibular migraine, came with true rotatory vertigo and turning to either side. Now, she had visited me last year in 2024 May, when I recently started my practice, and she had recurrent posterior canal BPPVs, which were sorted that time. And you can see that she is the most recent patient I've seen now of BPPV, and that's 1st March. One interesting history in this patient was that she had extensively fasted for some religious reasons in the last 1 month and traveled extensively for her pilgrimages. So again, because she was already a known case, so didn't want to miss anything which might be different or interesting. Of course, on Dixolpite, it was not showing a classic posterior kind of presentation. So I went ahead and took her on a VNG. So just follow the movement of this head of this model below. Yes. So as you can see, this was a McClure-Pagnani test. The head is being rotated on the left side. And as soon as the head was taken to the left side, there's a classic right beating nystagmus which was seen. So on turning the head to left, if you get a right beating, so you can see it is beating away from the ground. So it is a apogeotropic BPPV, left lateral canal apogeotropic BPPV, which was there. Now these are the VNG graphs. You can see on turning to the left, there is a right beating, and on turning to the right, there is a left beating nystagmus. And how do you sort of decide what it is? In short, for the PGs, again, the right red color that you see indicates the right eye, and it's sort of showing a sawtooth pattern. And this sawtooth pattern is beating to the patient's right. So it is a right posterior, it is a right nystagmus, okay? Right beating nystagmus. And similarly, vice versa, this is a left beating nystagmus. So what we learned from this case would be that always consider a history of vestibular migraine in BPPV patients. Now, what might be the correlation? There's a very strong correlation between the two. If uncontrolled vestibular migraine is there in these patients, they sort of get predisposes them to BPPV. And the biggest trigger, which we, as we already heard in her, was that the fasting and the extensive traveling that she did in the last 1 month. Moving on, this was a 32-year-old patient with history of true rotatory vertigo lasting for few seconds. He did not have any typical migraine triggers, no history of migraine at all, only history of migraine in the mother on family history. Again, now in this patient, we did the gaze protocol to see what happens. I mean, as you can already see, there is a baseline left beating nystagmus. Again, the sawtooth pointing to the patient's left is the left beating nystagmus, which was seen in this patient. And as soon as the patient in this gaze protocol, what you sort of do is you ask the patient to look to extreme right, then in the middle, then extreme left, then in the middle. So when he was asked to look in the middle, you can see that the direction of nystagmus has changed. It is now a right beating. Now, this is a very nice finding. You call it a rebound nystagmus. Why? Because you're sort of going in the other direction. Right? So, rebound is one of the findings you find, which is not a very sensitive finding. That means you might not see it in all the vestibular migraine patients. But in those patients whom you do, more so often than not, they have vestibular migraine. All right. Moving on to an 81-year-old male, and this will be the final case, complaining of an imbalance, okay, which started as a true rotatory vertigo, let's say, I think 7 to 8 years back, what he told me. ENT neurological examination, completely normal. Then what's the issue? Okay. He sort of felt very dizzy just for a few seconds. So a lot of other diagnoses were ruled out. Then we thought of doing, let's say, because he was an 81-year-old, as you can see, let's evaluate his cardiac health. He had sort of ignored his health and not visited his MD in a while. So this is something known as an orthostatic BP protocol or a BP vertigo BP protocol. Now, what you do in this is ask the patient to lie down quietly for 10 minutes, and instantly when they stand up, record the BP at the first, third, fifth, and 10th minute. Why first and why 10? Because there are known cases of transient orthostatic hypotension and delayed, which is even presence after 10 minutes. So you have to record. Yes, it takes time, but then in these cases who don't get a diagnosis for 8 years, I think you can spare few minutes. So these are the few diagnoses, which is orthostatic hypotension, postural orthostatic tachycardia syndrome, vasovagal syncope. This kind of things you can see an orthostatic BP which is dysregulated. You can see we were recording the BP is 145 by 66 when he lies down. So after standing, at the first minute, see 98, more than 50 fall in BP, and any 20 fall in BP is significant. See post 3 minutes, 119, roughly 120, still less than 144. Post 5 minutes, again 103, and post 10th minute, 108. So it's a sustained fall for the 10 minutes. So this is sort of a faulty autoregulatory function of the BP, and it is an autonomic, it can be due to autonomic failure in elderly patients. I told him to get Holter monitoring done in this patient before a tilt table test. There's also something known as a tilt table test, which our cardiology friends are routinely doing. So you can clearly see what we found in a patient who came to ENT clinic. Ventricular ectopic, basically he had supraventricular tachycardia, but what is he presenting as? A vertigo and imbalance. All right. And yes, there's one more case, very interesting. I'll just take few minutes. This was a 54-year-old gentleman who complained of imbalance and blurring of vision while walking. He did not have the typical rotatory vertigo, internal or external, but he had an imbalance while walking, especially while sitting, he was more sort of comfortable. And this walking aggravated in dark and uneven surfaces. So people who are practicing neurotology, like Prashant sir is doing regularly, he will say that what is there in this? It's a bilateral vestibulopathy which comes across. So let us find out what was there in him. So you can see there's a very faint, if you have a properly see, there's a very faint sort of oscillatory nystagmus which is there, and it's sort of continuous. And then we went ahead, and fundus examination is an important armamentarium actually of a vertigo clinic. So fundus examination was done because we saw this very faint uh, pendular oscillatory sort of nystagmus. That's a fundoscopy in progress. You can see that his fundus is clearly moving. Sort of, you can see pulsations in the fundus examination. And on ENT examination, you will be surprised. You can see the palate, oropharynx examination, that the palate is also oscillating. Can everybody note? Yeah. So what is this? This is a palatal tremor which was there. Now, what is the diagnosis? It was a case of oculopalatal myoclonus. Now, this our neurology friends will know better, but this is sort of a disorder. I can say broadly, it's some red nucleus area which happens. So what we learned that a basic ENT examination like an oropharynx examination helped us pick up an oculopalatal tremor case because we observed the palate oscillating. All right, that too in a pure vertigo case. And fundus examination, as I said, is an integral part of neurotology practice. So I would like to take a moment to thank my guru and mentor, Dr. Srinivas sir, for making me who I am today, and the countless women and doctors I have sort of interacted in the last few years. I can only count my blessing that they were a part of my life, and I was fortunate enough to mentor them. And thank you.
Thank you, Krupa, for a very nice lecture. It's almost you have covered all the practical cases which we see in our ENT practice.
Yes.
Only one question I want to ask you: how much importance you will give for the history, and how much time you will
Yes.
spend?
It's a very nice question. So can I stop sharing first?
Yeah, please.
Yeah. Sir, history, what I have done is I sort of have made a question in. So what my assistants do is they first give them that. Now this comprises a very basic, which includes all these cases like this patient, this palatal tremor, he also had mild dysphagia here and there, but he had missed that. So when we go deep in the history, then they sort of start saying yes. So that is the first line. And then I sort of check that questionnaire, and then again 10 to 15 minutes I definitely spend. I have to
Yeah,
make
and
sure.
also we should encourage people to do not forget our basic examination like blood pressure, pulse,
Yes.
touch, pain, temperature, and you have clearly showed a case where there was a good case where we have recorded the blood pressure in both supine and standing position, and it was utterly they were all good cases. Yeah, thank you for this nice presentation. Thank you,
Thank you,
Krupa.
sir. Thank
Amrapali,
you,
over
sir.
to you for the next section.
Yeah, excellent presentation, Krupa.
Thank you, ma'am.
As usual, you were very good. I have one question though, it is
Sure, ma'am.
non-academic. I am just intrigued, like how did you choose vertigo as your field of specialization? Now, as far as we go, for us, vertigo is like maths. Either if you have interest in it, you understand it all. If
Yeah.
not, then you just try to stay afloat. So,
Yeah.
what made you choose this field
Yes.
specifically?
So, ma'am, let me tell you, there's a very interesting story which is also attached to this. What happened is it's a personal experience. One of my family members, probably when I was in final year of MBBS, she had a very bad vertigo attack, and they sort of, the doctor of the family, even though in MBBS,
Right.
they want me to treat them. Now, I was clueless. So I was here, and that too from my vacations, and I saw her, and I'm like, I don't know anything about what is going on with her. So I, in fact, referred her that time to, I remember, Metro Hospital, Amit Seth sir and Damle sir.
Hmm.
Then she was
Right.
treated there. Anyways, she was a vestibular neuritis case. So that one thing always stayed with me as an ENT also ki, yeah, this field is very ignored. We are not taught. And again, let me tell you, ma'am, I was not taught anything in my diploma days, didn't learn anything much
Right.
in DNB days, tried to read a lot of books, but then didn't make sense. So I thought I should go ahead and follow this very intriguing sort of science. And I feel
Right.
that cases of vertigo in the community are on the rise. and it's more so also a need of the community more than
Absolutely.
because it's no more a garden variety of diagnosis of an older age or a disease of the elderly anymore. I see 16-year-olds with vertigo, I see 14-year-olds with vertigo, and of course migraine. So we need to do something about this case. So I decided to pursue this ahead, and I'm happy that I did it.
Excellent, excellent. Thank you very much, Krupa. That was a
Thank
lovely
you, ma'am.
story. And so now we move on to our next speaker, Dr. Vani Gupta. Dr. Maya Shankar, can you please introduce our next speaker? Dr. Maya Shankar.
Yes, madam. I would like to welcome Dr. Vani. Vani is completed her MBBS from KMC Medical College, Bangalore. Manipal, sorry, KMC Manipal, and MSc from Father Muller Medical College, Bangalore. She have completed a laryngology fellowship in under Dr. Nupur Madam and trained under Dr. Madhuri Mehta under otology. She is practicing in Seven Hills as a consultant, and she is a committee member of AOI Mumbai. She is passionate about laryngology and otology, and I'd like to welcome her and we could request her to start her session.
Thank you so much for the introduction, sir. Can you all hear me?
Yes,
Okay, great. Ma'am, is my slide visible?
yes, yes.
Okay. Before I begin my talk, I would like to thank Amrapali ma'am for this great initiative on Women's Day, and really happy and honored to be a part of this series. So, let's talk when we come to laryngology. Before getting into the detail of it, I think most of us, even in our MS days, have been, at least we have in our department had one scope, whether it was a 70-degree scope. In my case, we did not have 70-degree scope also. We had a 45-degree scope, the one we use for FES, and that is what we used to angle like this and somehow manage and see the larynx. So, with one scope, one rigid 70 scope or one flexible scope, there's quite a bit of things we can still do. You don't have to be a laryngologist. You don't need to have such a great setup to be able to diagnose at least the basic laryngological condition. So this is what I want to cover up in my talk today. So now, as I mentioned, there are two types of scopes one would like to have. One is a rigid scope, one is a flexible scope. Now, rigid scope, we use it in our OPD setup. Patient comes with change in voice. We can do it either in the OPD setup, or if we get a reference, indoor reference, or we can do it bedside. Flexible is useful when there's excessive gag in the patient, when rigid is difficult, when the larynx is so anteriorly placed that you can only see the epiglottis. If you want to assess swallow of the patient, of course, you can't use rigid because you're holding the tongue and then it doesn't become a physiological swallow. Assessment of a singer's voice. Now, when you are gonna assess a singer's voice, you want the singer to sing. And at that point, if you're holding the tongue, you can't do that. In ICU setup or a patient who is to be decannulated, whether we can remove the tracheostomy tube or not, flexible scope is the one I would prefer. Coming to basic, some of the diagnoses we routinely see in our OPD. This is a vocal fold polyp. As you can see, it looks like it is a hemorrhagic polyp on the right vocal cord. There is also a small contact lesion on the opposite side. We can see the feeding vessel. This is the scope I've used in my OPD. I have intentionally not used the expensive Olympus scope we have. This is a simple scope I have in my OPD. Same I use for the otoscopy, for nasal endoscopy. And you can see a feeding vessel going to the polyp. You can also see probably an underlying sulcus. Let's see a vocal fold cyst. Now, cyst is, it can be a mucus retention cyst, it can be an epidermoid cyst. Over here, we see the left vocal fold of the patient and the striking zone. Striking zone is the point which comes in the maximum contact when we are talking, and that is the area where we can have this vocal fold lesions. These are also known as phonotraumatic lesions. Here we are going to be seeing vocal fold sulci. We can see there are bilateral sulci on the vocal fold and hence a huge phonatory gap. This patient had presented to us with voice change. Showing this is the one of the cysts that I had operated. This is on the left vocal fold. You can see pre-operative picture and post-operative picture. They're sharing the voice of the patient as well. This is what we call as maximum phonation time. In an adult male, we expect it to be around 45 seconds, and in an adult female, around 35. As you can see, this is a 16 to 17 seconds, showing that the voice, the maximum phonation time is significantly reduced. So the way to go about the surgery for this is a microflap technique. Of course, I'm not going into detail about the surgery, but when we suspend the larynx, put a neuropathy below the larynx, and we make a cut. First, we give infiltration, make a cut just lateral to the swelling, and after that, we raise the flap. We open it like a book, remove our lesion, and we save this epithelium. Now, this epithelium is gold. We do not want to waste it. We put it back, and it heals beautifully after some amount of post-operative voice rest followed by therapy. This can also be used when this patient, it was a good history. This was an 82-year-old male. I remember Sardaji walks and he says, "Madam, मेरे ना नाक के पीछे कुछ अटका हुआ है." So he was very specific that नाक के पीछे कुछ है. So I just put a nasal endoscope. I didn't see anything. He had no history of any kind of addictions. So just because he was elderly male and he did not complain of dysphagia, just naak ke piche kuch hai, I thought, let me just put my rigid scope. It is right there in my OPD. And this is what I saw. The posterior base of the tongue on the left side and the vallicula, you can see a huge growth over here. Surprisingly, he did not complain of dysphagia. There's also pooling of saliva, and with that same scope, I was able to angle a bit and look at his vocal folds, which were mobile and showing that the laryngeal involvement hadn't happened yet. This is another vocal fold case. So before this, we saw the benign lesions of vocal folds, and over here we are seeing malignant lesions. Over here, it's a right vocal fold, and you can see a feeding vessel also over here, and it involves, apart from anterior commissure, most of the vocal fold is involved here. Another useful tool which one can have in the laryngology setup is narrowband imaging. So this is basically a blue-green filter which enhances the blood vessels over the growth. Over here, we can see that right vocal fold growth was quite apparent, but even on the left on NBI, we can see some amount of growth. And over here, we can also in the subglottic area see some enhancement happening. So we go ahead with a CT scan, see the depth and involvement of extralaryngeal structures, and then go ahead with the treatment. This is a diagram just to show the various layers of vocal cord, the epithelium, the superficial and intermittent lamina propria, the deep lamina propria, and then the muscle. Based on the layer with what we have to excise is cordectomy. So how we go about it in the operation theater is this is another growth. We first make out if the vocal fold is mobile or not. We get an idea about the involvement of muscle that way. Once we suspend the larynx and we are able to excise the whole growth. So in this case, a very useful tool is if you have frozen section in your attached with your hospital, so you can see if you have margins free, you can send the growth and then you can send margin separately. And if that margin comes out to be negative, you know you're good to go. Otherwise, you will have to go another layer down and increase your level of cordectomy. Of course, there's other option of going for radiotherapy depending on the preservation of voice. With radiotherapy, preservation is better than with cordectomy. Vocal fold palsy is a very common condition we see in our clinic. Over here, we see a right vocal fold palsy. The left one is trying to compensate, and by doing so, the arytenoid is also internally rotating. Many of these causes can be idiopathic. They can be after surgeries like thyroid surgeries or any cardiovascular surgeries. Coming to the flexible scope, this is my personal favorite scope. I have a huge bias towards this scope. So one of the main thing I use this scope is for swallow assessment, which I can do bedside at patient's house, in the ICU setup, or in the OPD setup. Basic requirements that you need for it is basically a flexible scope. If you have a suction channel attached to it, well and good. Even if you don't, it's all right. We use 3 consistencies of food: puree, semi-solid, and water. I've added a green color commonly found in the market to enhance the color and have a good contrast against the pink mucosa of the larynx. Of course, a light sauce and lignocaine jelly Please note that we don't anesthetize the patient. We don't put Otrivin in the nose. We don't put lignocaine spray, nothing. We don't want to spray the larynx or anesthetize the larynx because we are making the patient eat. This was just a video of a normal flexible scopy that we do. Over here, when I've given the food to patient, you can see whiteout sign present. That is for a moment. You don't see the larynx at all over here. So that is a normal laryngeal elevation. You can see green stain over here. Patient has taken water over here and has been able to swallow the whole thing without any aspiration, penetration, or pooling. So when we go about reporting a swallow assessment, it has two steps. One is without giving bolus. So that is when you just put the scope, the first thing you see if there's any pooling of saliva in the hypopharynx, in the piriform sinuses. If at all there is any saliva pooling, is it aspirating or penetrating inside the laryngeal introitus? Look for whiteout sign, which we saw in the previous video, vocal fold movements, and laryngeal adduction response. Laryngeal adduction response is a protective response. When we touch the larynx, the arytenoid of the larynx, the vocal fold closes. This is also a protective reflex. Once we give bolus, we start with consistencies which is easy for the patient to eat, to swallow, and then we go towards difficult. We see findings like we have to look for any premature spillage of the bolus, any pharyngeal pooling, any aspiration, any penetration, or any reflux from the cricopharynx back to the larynx. Not going into detail with all the findings, I'm just going to show few ones which we cannot miss. This is a larynx where we see with the one advantage of flexible scope, you can go very, very close to the larynx. This is why I love the scope. You can see there was pooling of saliva everywhere, and this patient is frankly aspirating the saliva. Now, if this were a reference which has come to me for potential tracheostomy decannulation, or to see if the patient can be started orally, as we see there is aspiration over here. Patient was not able to cough his own saliva. So this is what I call as silent aspiration. This is a patient, a young guy who met with a railway accident. We had done a tracheostomy to maintain airway on emergency basis. And this is something we don't see very commonly. This is a Riles tube in situ. If you see throughout the video, I have a nice 10-minute video of this flexible scopy. There is no whiteout sign. The larynx isn't elevating. This is penetration and aspiration. This is the worst case scenario you can have. This is the green color we have given food. As you can see, this is the arytenoid. This is laryngeal inlet over here. There's pooling in the cricopharynx and piriform, and then you will see this green color enter into the vocal fold. Yeah. Okay. Yeah. Just playing this one again. So this is the green color entering the larynx. You can see the vocal folds are stained. So now, if I were to choose between one scope, putting cost aside, if I go for a simple scope, a rigid scope, or a flexible scope, I would definitely want to have the flexible scope. Reason being, there are a lot of patients who have gag. We can surpass that by using a flexible scope. It is relatively painless as well. It is more physiological in respect to both voice and swallow. I can make the patient eat. I can make the patient sing. I can make them phonate in their normal frequency in their voice. Other tools which would be useful, which I have not shown right now, is stroboscopy. Of course, NBI can have audio connected so that we can check the frequency, fundamental frequency for the patient when they're speaking. That is especially useful in singers, and if you're looking for any transgender surgeries to change the pitch. These were very basic pathologies I've shown. Some other ones are like vocal fold web, neurological pathologies like vocal fold tremor, or adductor or abductor spasmodic dysphonia, and arytenoid granulomas. There's a huge atlas for them. Before I finish my talk, I would really like to thank everyone to be present here to for having listened to me. Special thanks to my mentors who also happen to be great women and women who have achieved a lot in their life and are a huge inspiration to me. Dr. Nupur, who is my guru under whom I have been trained in laryngology, and of course, Dr. Madhuri Mehta, my other love of life. As I always tell ma'am, probably the first love of my life is always otology, and I'm really thankful to ma'am for getting me to love otology. So over to you, ma'am, for any questions.
Any questions, Maya? So
No,
Vani,
madam.
okay. So Dr. Vani, I would like to ask you. I have many residents who are confused about the field of specialization that they choose post their residency or post their MS. Okay, now you have chosen this field very early after your MS. All right, and there are a few women faculty today, like Dr. Josna, Dr. Sunita, who have chosen their field much later after their years of practice. So I would like to ask, in fact, all of you, Dr. Josna, if you're there, and Dr. Sunita and Dr. Vani, is it easier to choose a field of specialization early on in your practice, or is it more convenient and easier to choose that field of specialization later on in your practice? Is there any difference at all? What do you think, Vani?
And for me, I think what mattered the most was exposure. In my during my residency, as I told you, we did not even have a 70-degree scope. My first job after my residency was in Sion Hospital. Over there, the first time I held a flexible scope, I knew it was my calling. Was exposed with everything in that place, whether it was cochlear implant or it was vertigo, allergy, laryngology, skull base, angiofibroma, but somehow I felt this was my calling. The cherry on the top was me attending a phonosurgery workshop of Dr. Nupur. I remember I went there. Those 2 3 days were enlightening, and I knew this is what I want to do. So I think it was just the exposure of these things that got me thinking that this is what I want to do. So I think ma'am will be able to tell better what got her
What do you
choose.
think, Dr. Josna? What about you? What is
Very
your
well said,
experience?
actually, Dr. Ani. What I feel is the opportunities which were there maybe 25 years back, which were very much different that time. And nowadays, they are blessed or lucky to have much more opportunities and fields to explore. So if I can see rhinoplasty or the facial plastic surgery were not as much explored that time when we started our practice. And luckily, I got the opportunity to go to Germany immediately after my post graduation, and then however even after that there were not many opportunities to settle down only as a rhinoplasty surgeon. Maybe I had to start my ENT practice and then get the patients for rhinoplasty and then build up the career. But nowadays with social media and uh, the opportunities to get mentors, even that was very difficult that time. Now you can easily get mentors. You have so much data available on social media as well as internet, YouTube. So that is one more advantage. And even if I feel even I feel that in case if I was to do my post graduation in these days, I would have chosen as a rhinoplasty plus facial plastic surgery as my career to start with my practice. So definitely newcomers and juniors are very much they have great opportunity to choose their career at the start of the practice. Definitely they have to explore what they like to do and choose their mentors and then start as early as possible. That's what I feel.
Absolutely. Very good. So excellent lecture, Dr. Vani, and thank you very much for sparing time from your holiday. We are
Thank you,
grateful.
ma'am. Thank you so
So,
much, ma'am.
so we move on to our next speaker, Dr. Josna Jagtap. Who does not know her? She is the director of Dr. Josna ENT Hospital, Thane, and she is a visiting rhinoplasty surgeon almost everywhere in Maharashtra. She has a special interest in structural as well as preservation rhinoplasty. She was also the ex-president of Thane AOI and is the founder member of ARCI, that is the Association of Rhinoplasty Society of India. She is invited as a faculty in many national and international rhinoplasty conferences and workshops. Not only that, she herself organizes so many rhinoplasty life surgical workshops in Thane and also runs a fellowship program in rhinoplasty for training junior colleagues. Over to you, Dr. Josna, for your presentation.
Thank you so much, Amrapali. Also, I thank Mumbai AOI and Sun Pharma for organizing such a wonderful webinar. So I will start sharing. And definitely, I would like to wish everyone a happy International Women's Day. I suppose you can see my screen. Can you see my screen? The
Yes,
PPT?
yes,
Yes, ma'am. Yes, ma'am.
absolutely. Yeah.
So these are the famous Bollywood personalities who have opted for rhinoplasty to enhance their beauty. We have been doing structural rhinoplasty since last many decades, but nowadays the era is changing, and the future of rhinoplasty is preservation or hybrid rhinoplasty. So basically, how does it differ from structural rhinoplasty? What we used to do in structural rhinoplasty is separate the upper lateral cartilages from the septum, do the osteotomies. So it is actually making of 3 compartments and then reduce the deformity and then resuture or reconstruct the whole of the nasal structure. While in preservation rhinoplasty, what we do is preserve and reshape the existing structures. And the hybrid or partial preservation is when we utilize the concepts of both and do the rhinoplasty by using more of preservation and maybe structural for the tip plasty. So why one wants to go for preservation rhinoplasty is we are replacing resection with preservation. So there is more of manipulation and less of excision. And as we are preserving more of septal cartilage and not taking out much, the revisions required are minimum, and whenever they are required, you don't need secondary rib reconstruction because already the septum is available in case if the revision surgery is needed. So basically, it consists of 3 parts. That is the soft tissue envelope preservation, nasal dorsal preservation, and the alar cartilage preservation. So in soft tissue envelope preservation, you go in the subperichondrial, subperiosteal plane. In preserving the nasal dorsum, when you're removing the hump, you don't cut it from the above. The roof is not cut while you work at the base of the nasal pyramid. And in alar cartilage maintenance, there is less of excision and more of manipulation or suturing techniques. So how does it differ from normal structural rhinoplasty? So it differs mainly in doing the osteotomies, especially in surface technique where the foundation technique where the osteotomies are done like lateral osteotomies, transverse osteotomy, and the radix osteotomy. And you reduce the bony vault by push down technique after you dislodge all the bony vault from the underlying structures, or a let down technique where you are doing the resection of the lateral wall of the bone and letting it down, letting the bony wall down so that the hump is reduced. However, you can manipulate this bony vault so that not only hump cases can be treated by preservation rhinoplasty, but even crooked noses can be treated by preservation rhinoplasty. So roughly preservation rhinoplasty is divided into type 1 and type 2. I won't go into much details, but I will be showing 2 cases where one case is done by high strip method and one case is done by low strip method. What is low strip or high strip? It is the excision of the cartilage where you excise the septal cartilage. Either you take the cut higher level or at the lower level as we routinely do in the septoplasty. And the osteotomy remains the same as I described before. So this was my first patient. She had deviated, minimal deviation of the nose to the right with V-shaped hump involving bony as well as cartilaginous dorsum and a slightly bulbous tip. So you can see in oblique view, the hump is very well seen. In the basal view, you can see that the nasal tip is deviated to right. She has got caudal dislocation, so the nostril shape is unequal. So this is a small video. We'll just show the relevant steps. So after open approach, the septum is separated from the maxillary crest, anterior nasal spine, vomer, and the perpendicular plate of ethmoid bone. So as you can see in this picture, the red line shows where the quadrangular cartilage is separated from all around, so that once this quadrangular cartilage flap is made, then the perpendicular plate of ethmoid is cut so as to reduce, and so that you get the movement to the quadrangular cartilage, and the subdorsal triangular wedge shape excision is done where the bony hump is there. So after doing this, you get the quadrangular cartilage flap. Also, patient was having a little bit of septal deviation, so lower strip of the septum was excised. Then the osteotomies were done. So you can see the markings for the transverse osteotomies, the lateral osteotomy on both sides. So transverse osteotomies were done at the medial canthal level. These were done by percutaneous osteotomy method with 3 mm osteotome, as usual as in structural ways. Then the lateral osteotomies can be done by piezo or with guarded lateral osteotome, which can be done by internally at the piriform aperture. So as I said, patient was having deviated nose to the right. So automatically patient is having little bit a longer length of the nasal wall on the left side. So you can see I have made 2 lines on the left nasal wall where the ostectomy was done, and this part of the nasal bone was excised, so that I can push down the nasal bones, nasal vault down. So the hump is reduced, as well as there would be equality of the nasal wall. After doing lateral osteotomies, radix osteotomy was done at the same level, is through the same incision as the transverse osteotomy. There was small cartilaginous shoulder was there, which was excised. And you can see now, this was the preoperative picture. And then the intraoperatively, I can reduce the quadrangular cartilage. I can just rotate the quadrangular cartilage flap and reduce the hump. Now this quadrangular cartilage flap is mobile, and I can fix it to the anterior nasal spine, as well as it was fixed to the maxillary crest. And then the rest of the tip plasty was done. I will not go into too many details because it is a little bit larger video and because of the time constraint. Then the septal extension graft was put and the tip plasty was done by taking intra and interdermal sutures. So this was the SPQR, that is a simple preservation quick rhinoplasty with osteotomies, internal osteotomies, left ostectomy and osteotomy. And now you can see immediate postoperative result where the hump is reduced. Patient is the tip which was droopy, which is lifted up. Patient is having better tip projection, good dorsal aesthetic lines. The tip of the nose was tilted to right. Now it is in the center, as well as the nostril shape is much better than before. And the same patient 1 month postoperatively, little bit edema is there, but then the hump is gone and she is having good dorsal aesthetic lines. This was the one patient where I have done preservation rhinoplasty with low strip. Another patient where preservation rhinoplasty was done with the high strip. So these are the patients who are typically can be taken for preservation rhinoplasty. Patient is having hump, having most of the septal cartilage, which is straighter, and Caucasian type of noses, where you don't want to dissect more of the dorsum because they have thin skin and any irregularity will be seen post-operatively. So the preservation technique is much suited in this type of patients. So this is the patient who had come basically for aesthetic correction. She had deviated nose, tip was tilted, deviated to left side. She had thin skin and droopy tip. There was hump over the dorsum, and she had minimal DNS with spur. So these were the steps. And this is a short video of the same patient. So over here, I have done high septal strips. Before that, I have taken one cartilaginous piece from the mid part of the septum, which is 5 millimeter by 2 centimeter in size, so that to put it as a septal extension graft. Then there was septal cartilage was excised as the inferior strip, and now you can see high septal cut was taken so as to separate the septum from the upper lateral cartilages. So in diagrammatic representation, first I have taken this triangular graft for septal extension graft, then high septal cut is taken usually at the W point, and then so it will look like this in the lower picture. And to fix the upper lateral cartilages to the septum, dorsal fixation sutures were taken. So you can take internal sutures, at least 2 to 3 sutures, to fix these upper lateral cartilages to the septum. So this was the post-operative picture. Then the tiplasty was done as in a structural way. So this is the picture where better dorsal aesthetic lines, hump was reduced, the droopy tip is elevated. The lateral view, again, the hump is gone, the tip projection and rotation is much better than before. The basal view and the frontal view, where you can see better dorsal aesthetic lines. She wanted nose to be a little bit shorter because it was droopy and making it to look more longer, and patient is happy. So similar case, preservation rhinoplasty. Again, this was SPQR, low septal strip. So whoever wants to start with preservation rhinoplasty, I feel that one should go for the low strip technique because it is the similar way what we do in septoplasty. And then over here, there was little bit radix depression. So it was filled up with the free dice cartilage. You can see the lateral view, the oblique view, right oblique and left oblique, good dorsal aesthetic lines, nasal tip projection is better. The nasal tip is in the midline. Another patient recently done, 1 month post-operative. She had a crooked nose, which was also done by the preservation technique. And you can see good straight dorsal aesthetic lines, straight dorsum, good tip diamond shape of the tip. You can see the deviation to the left side, which is again totally corrected. This patient was a little bit easier because she didn't have any deviation in the bone. So the osteotomies were done only to reduce the body vault and not for deviation or hump noses. Little bit hump, which was there, was more of cartilaginous, so that was easier to reduce. So this is the happy patient at the end of 1 month. So to conclude, dorsal preservation rhinoplasty is an advanced and evolving technique. It offers numerous advantages to the patient, such as natural looking dorsum, faster recovery, and lesser morbidity. As I said, there are revision surgeries which are less commonly required in these cases, as we are preserving most of the septal cartilage, as well as so the reconstruction can be done without using the costal cartilage. But it is not that you can directly go and learn the preservation rhinoplasty. Whoever is new to rhinoplasty should know the structural steps of structural rhinoplasty, and preservation rhinoplasty is add-on features so as to you can expand your surgical arsenal so that you can offer the greater options to your patients for best results, and you can choose the patients accordingly. So these are our Instagram and for website. Thank you so much for patient listening. This was recently I had gone to US and was blessed to have good mentors over there to learn the preservation and hybrid rhinoplasty. So I feel you are always a student who wants to learn, and these are our fellows and observers who's with whom you keep on learning more and more. Thank you so much.
Any questions from the audience? I guess there are none. Next lecture, Dr. Jana, as always, thank you for your invitation. We will move on to the next speaker. Janvi, can you introduce the next speaker, Dr. Sunita? Dr. Janvi?
Hello. Hi. Sorry, there was some glitch.
No problem.
So I would like to invite Dr. Sunita Shukla. She's the founder and director, Mumbai Allergy Center, India. She's the head of Department Allergy Sciences at HN Reliance Hospital. She's honorary consultant allergist at KEM Hospital. She's editor-in-chief, Annals of Otology and Neuro-Otology. She's done advanced allergy training from Harvard Medical School. She's been awarded Dr. Henry Kalaman Gold Medal Award. She's been awarded Dr. V. Raju Award, first prize for the best research paper, the best scientific researcher 2017 by Prime Minister Office of India, International Visiting Scholarship USA, Jewel of India Award, National Mahila Ratan Gold Medal Award, International Excellence Award, Times Leader Award 2023, Allergy, Outlook Magazine, Best Doctors Maharashtra 2025, Allergy Queen of India. Welcome, ma'am.
Hi, thanks Janvi for the kind introduction. Good evening, one and all. At the outset, thank you Amrapali, AOI Mumbai for giving me this opportunity. So I wish all of you a very happy International Women Day. And with this, let me talk about my passion, that is allergy, and I will answer Amrapali's last question at the end of my talk. So coming to what is new in allergy, we all know in allergic rhinitis, your treatment is based on 4 important pillars. One is how to do a precise allergy diagnosis, that is by skin prick test. Whatever allergens you find positive, ask the patient to avoid those allergens. Treat your patients with pharmacotherapy because symptom relief is important at the end of the day. And once you know the root cause of the allergies, you'd start treating that allergen with immunotherapy. And with this, the quality of life changes and you modulate the whole disease. So allergic rhinitis classification, which was given by ARIA in 2008, we all know. And here the important thing is they gave a lot of importance to quality of life in terms of sleep, whether it affects your daily activity, your work, school, and so on. So quality of life is a very important parameter. And now today in this talk, I'm talking all about the recent updates in allergic rhinitis. So once you have a patient with AR, do always ask the history of smell, whether it is hyposmia, anosmia, and so on. And IPOS 2020 guideline says that you can take a SNOT 22 questionnaire to understand smell and the quality of life. But the most important one is a visual analog scale, which is advertised by ARIA and the Euphoria. This is my personal favorite also because as you can say, it is a very simple scale from 0 to 10. And even if the patient is illiterate, you can ask the patient about his symptoms, whether he is a happy green face at 0 or he is an angry red face at a level of 10. So this becomes very nice to understand what is the quality of life of the patient. These are the recent ARIA guidelines put forth in 2020, and they basically talk that how do you assess a patient of allergic rhinitis based on the visual analog scale. So in a nutshell, take a history by VAS, understand the symptoms, and then you can step up or step down your treatment. And the mainstay of the treatment here is intranasal corticosteroid with or without antihistaminic and the second generation antihistaminic. And if it is a severe case, you can always refer to an allergist or a immunotherapist. This is the latest euphoria guidelines, which talks about that if a patient has severe allergic rhinitis and if there is a failure of previous treatment and you can't give a good symptomatic relief to the patient, then you have to consider allergen immunotherapy, corticosteroid surgery, or add-on therapies. But the last statement which they make is, if you want a sustained effect of allergic rhinitis treatment, the only option is allergen immunotherapy to dust mite or pollens. This is a snapshot of all the international guidelines, whether it is Euphoria, ARIA, EPOS, Airway ICP, and so on. And this is based on the concept of precision medicines, where we have the 4P, which you can see on the right-hand side. And they also use the visual analog scale, that is VAS, for judging the allergic rhinitis symptoms. And they say if it is a control AR, you still continue the treatment, but you consider AIT, which is allergen immunotherapy. If it is an uncontrolled AR, you continue the treatment, escalate the treatment, and then consider AIT. And once the patient is better, again consider AIT. And again, it is not uncontrolled, still it is uncontrolled, you again consider allergen immunotherapy or surgery. So why all these guidelines? 4 of the international guidelines here, they talk about allergen immunotherapy for all the allergic rhinitis patient. What has changed post-COVID or post-2020 that everyone is talking about AIT? So we have to understand that whenever we give pharmacotherapy to the patients, whether it is steroid spray or antihistaminic, we are giving only symptomatic relief to the patient. The symptoms are decreased till the time patient is on medicines. The time the effect of the medicine goes away, the symptoms are back. So once you know what are the allergens causing the allergic rhinitis, we give them immunotherapy, which is actually the treatment for the root cause problem of the symptoms of AR. So allergen immunotherapy has many ways of being giving. Subcutaneous has been on for more than 110 years, but the latest one is a sublingual route, which we can use in India. And this is the only treatment which actually modulates the disease from a Th2 variety to a Th1 variety. And there are various other benefits of allergen immunotherapy. They can be given in any form, whether it is injection, drops, OIT, intralymphatic, EPIT, and so on. And there are so many new developments. So basically, what does immunotherapy do? It will decrease the symptoms. It will decrease the medication use. It halts the present allergies, and it also prevents new allergy increasing, and it increases your quality of life. Most of the time, a allergic rhinitis patient will also come up with polyps, which will be a most important symptom of CRS with nasal polyp. And this is the picture. And many times you will see that though a good surgeon will have done a good FES and a surgical clearance, these patients come back again and again. So it is not a surgical problem, but it is a medical disease. And that's why the treatment lies in the medical management. And this is very typical when we see such recurrent polyps. This is called as central compartment atopic disease, where on CT scan, you see that all the haziness is basically in the nose and the sinus area and not on the lateral part. The reason being that whenever the air enters the nose, that is the commonest area. This is the commonest part where the allergens will hit the terminates and the nasal mucosa, and that's why the haziness is much more. And this is very typical of a allergic rhinitis patient. So the recent update is that we have to understand the endotypes and the phenotypes is any of the CRS, especially with nasal polyps. We have the Th1 variety, which basically is because of lot of neutrophils, but we also have the Th2 variety, which is basically more of eosinophilic variety, and lot of IgE is positive in this. Once we understand the problem and we say that this is a Th2 type of inflammation, the game changer here becomes the biologicals, which have just entered into the market for CRS with nasal polyp and many of the other IgE-mediated diseases. So for CRS with nasal polyps, we have omalizumab, dupilumab, and many other stuff. But for ENT doctor, omalizumab is practically possible now, though dupilumab is in the market, and this is one of the best for CRS with nasal polyp. It is still not available, and we are still managing with omalizumab, which was the first of the prototype of biologicals, which is for anti-IgE. This is a small video of the biologicals where you can see that these are the circulating IgE which are present on the mast cells. Now, whenever an allergen enters into the body through whichever route possible, it attaches on these mast cells and you get a degranulation of the mast cells, giving rise to histamine and the chemotactile receptors. And the symptoms. Once we give omalizumab, these omalizumab bind to this IgE, free circulating IgE. Now they are not available. So eventually their number on the mast cell decreases, and now we don't have any IgE which will cause any reaction. And that is how it changes the whole scenario of a IgE mediated diseases. Now, again, looking at this patient, this is a case who was operated 4 times, had allergic rhinitis, and was referred to a senior ENT colleague for management of the polyps and allergies. And this patient was given allergen immunotherapy for dust mites, and you can see with omalizumab, within 3 to 4 months, the polyps have actually gone away. And this is what precision medicine is, because here you have to take into consideration what the patient wants. A patient who has undergone surgery 3 to 4 times, it is a very traumatizing experience for the patient and for the doctor that you please go for the surgery again. So these are the very few 5 to 10% of the patients where medical management for the allergies become important. But having said that, as ENT, don't worry, FES will be the commonest surgery to be done for nasal polyps, and no ENT specialist or allergy specialist is going to take away your surgeries away. So this is only for those 5 to 10% of the patients. So at our Mumbai Allergy Center, now because I'm practicing only allergy, we have given omalizumab for more than 1,200 patients for various type of IgE diseases, whether it is CRS with nasal polyp, urticaria, asthma, or so on. And the results are very promising. One more subset of allergic nasal rhinosinusitis is a AFRS, and we know it is a subset of CRS. And the recent research says that if a patient is hypersensitive to the fungus, he usually has AFRS. If he is immunocompetent, it is a fungal ball. And if there is a immunosuppression, we get an invasive fungal rhinosinusitis. And there are 2 schools of thoughts. But if you understand that this is a fungal allergic rhinitis, the allergen immunotherapy and omalizumab works wonders here also. Now, we all are facing a lot of pollution, whether it is Mumbai or any city in India, because the development has come at a cost. And most of your allergic rhinitis patient will say that their allergies have worsened, especially since the pollution has increased since November, December. This all will increase during the winter season and whenever the construction increases and so on. So whenever there is a pollution, it actually decreases the barrier function, whether it is skin or nasal mucosa, and causes a lot of oxidative stress. And the allergies, which will be like allergic rhinitis, asthma, atopic dermatitis, all of them will increase. And actually they convert a Th1 into a more Th2 or a allergic type of factor. So as far as possible, even if we are a normal person, we should try and avoid this pollution and prevent the oxidative stress which our body goes through. Let us see the real world evidence from Mumbai Allergy Center within 3 years of my private practice. And the proof is in the pudding. We have more than 2,500 patients of allergies and 1,100 are on immunotherapy. In patients with allergic rhinitis, if your selection of the patient, allergen, quality of the allergen, everything is good, in our scenario, 90% of the patient are off pharmacotherapy in the first 3 months of immunotherapy. But we have to tell the patient that this is a gradually process, and as we are escalating, your symptoms will become better and better, and it eventually improves the quality of life. Because whatever said and done, many of the medicine and antihistaminics, when they are taken on a long-term basis, do cause some of the side effects. I am an ENT surgeon. I have done ENT for 15 years and then I started my allergy practice. But as I started doing more and more of it, I went into other system also, like the lungs, the urticaria, and food allergies, drug allergy, and so on. And with this, I started my journey of allergy, and I have been traveling international level and presenting our data in the world. We spoke about how food allergy can affect. At the Asia Pacific Conference, also we spoke about biosimilar omalizumab at the American conference in 23. But this was a first of its paper in the world which was presented ever. And I'm very proud that this paper comes from India. And this was my thought when I was giving lot of immunotherapy to my patients in CRS with nasal polyp. I realized that their need for biologicals or omalizumab decreased. And we presented this data last year at the European conference in May. And the conclusion was that if a patient who is atopic, has allergic rhinitis and CRS with nasal polyp, the immunotherapy in these patients will decrease the use of biologicals, because finally it is AIT which changes the pathway into a Th2 pathway. So to conclude, for allergic rhinitis, whether we use pharmacotherapy or biologicals, they do give relief. The patient becomes better, but it is temporary. So allergen immunotherapy is like the champion who just comes with one revolver, one bullet, and he shoots in the bullseye, and wow, the patient is better. So allergic immunotherapy is the disease modulating treatment for all the allergies, and it should be considered for all the severe patients. Coming to one very interesting research which I did when I was doing my allergy practice was when I was studying something about peanut allergy and the skin reactions. And I really questioned that in Maharashtra, we all eat so much of peanuts, whether it is in breakfast, in poha, in our food. Then we have the peanut chicky and so many things. And still we never have a peanut allergy, whereas people are really dying because of peanut allergy in different parts of the world. And with this paper, I got the gold medal award, and it gave rise to another thought process of mine, which was then converted into a paper which I presented at World Allergy Organization in 2023. And the conclusion was that all food allergies are sensitized through the skin. And in India, we have this decade-long tradition where we do oil massage in infancy. And my say was that because we have been doing this oil massage since infancy, our skin is good, the mucosal, the skin barrier is intact, and that's why the food allergy sensitization, which happens through the skin, does not happen if we keep the skin intact. So I think somewhere our Indian culture is very allergy protective as compared to the Western world, but we are blindly following the Western world. My experience as an allergy specialist is that we as Indians have lot of protective values in our Indian culture. So let us Easternize the Western world instead of we following the Western world. So with this, I am proud to be an Indian. And again, I wish all of you best luck for this International Women's Day. And we will be starting a fellowship soon. I am just keeping this slide till the time we answer questions, so that anyone want to contact us for details or learning allergy, they are most welcome at my center. So thank you, Amrapali, once again for this opportunity.
Thank you so
Dr.
much, ma'am,
Sunita.
for the enlightening lecture. Over to you, ma'am. Amrapali, ma'am.
Yeah, any questions, Janvi?
No questions as of now.
No questions.
So
That
Amrapali,
was
I
an
would like to
excellent.
make a comment. The last
Yes,
question which
please.
you asked to all the females, I think as females,
Yes.
we are multitaskers, and we are basically a giver than taker. That
Yes.
comes with
Yes.
our X chromosome. So I have finished, I did my MS ENT 20 years back. I was a practicing ENT surgeon, and I was very good at my surgeries. But then once I started allergy, I went deeper and deeper and deeper into it. And now I do only allergy practice. I actually don't get time to do ENT practice. And I think we should see our life in a nutshell. Work should not be your life. It should be a part of your life. And because as females, we do so much of multitasking. So we should make our health a priority. So yes, you should go into a niche area. In ENT also, we have so many branches now. And especially for females, it is very good if you go into a niche area, because then you can concentrate more and more about less and less, which is the need of the hour. So best wishes to any female who want to go into allergy. It is a very nice field, wonderful field, and it is going to increase only. So you'll have lots of patients. Don't worry about that.
What an excellent thought, Sunita, and a wonderful presentation. I think it is the first time that somebody has actually supported the oil massage. and my husband is a pediatrician, and I think I'll explain this to him today. Thank you very much, Sunita. We move over to the next speaker, Dr. Anju Chowdhury. Dr. Maya Shankar, can you introduce Dr. Anju to the audience?
Yeah, I would like to welcome Dr. Anju Chaudhary. She is a consultant airway surgeon at Sefi Hospital, SRCC Children's Hospital, Wokhart Hospital, Breach Candy Hospital, Borivali Healthcare Center. Her area of interest is in laryngotracheal reconstructive surgeries. She have completed her MS ENT from TN Medical College and Nair Hospital. She is a gold medalist from Maharashtra University. She have completed a fellowship in laryngotracheal surgery at Prince Ali Khan Hospital under mentorship of Professor Philip Monier from Switzerland. She have gained experience in pediatric airway surgery from Cincinnati Children's Hospital and Medical Center, Ohio, USA. She have established an exclusive department of airway surgery and airway team with Dr. KK Easy at various hospitals in South Bombay. She's a faculty for hands-on training on airway surgery at Center of Excellence in Minimal Access Surgery and Training Center, Mumbai. She's an invited faculty in airway symposium at various national and international conferences. Welcome, madam.
Thank you, Dr. Maya, and thank you, Dr. Amrapali ma'am, AOI Mumbai. Thank you so much for this invite, and I must congratulate you for compiling all these talks together on the Women's Day especially. This is a wonderful idea, and I fully support it. I hope I am visible, audible, and
Yes,
my
yes, you are.
presentation I am going to share just now. Are you seeing my presentation?
Yes, yes.
Is it in full screen?
Yes, it is.
Yeah. So I'll start off. My topic of presentation today is management of tracheal stenosis, what's new. So as we all know, tracheal stenosis is something that comes to us quite commonly because probably we have a referral bias at our center, but it is not very uncommon. We see that most common cause of tracheal stenosis in our general ENT practice would be an intubational trauma, 85 to 90% present to us with stridor. There are 4 grades like grade 1, grade 2, grade 3, grade 4 Cotton-Meyer classification. That is around 50%, then 50 to 75%, 75 to 99, and then a complete stenosis. Traditionally, we've all been taught that tracheostomy is the approach to save life. This was our dictum even during my residency 15 years back. But as we evolve and as we go into minimal access surgery, we know that trends are changing. Now we have a lot of endoscopic treatments coming in. We have different varieties of tracheal open surgeries for tracheal stenosis. Something that is further advanced our practice is better anesthesia techniques because these obstructed airways would need better anesthesia techniques. And one step later, we would also need to prevent all these stenotic lesions because it's a very difficult problem to deal with. So first, what are the new things in our anesthesia techniques? First, I would say that it is Thrive, which is this tiny little machine and a probe attached to the nasal cavity with a very high flow oxygen delivered pre-anesthesia and during anesthesia, which gives us around 45 minutes of unobstructed airway time to work. So all our tracheal stenotic lesions and even those our ML or certain other airway procedures can be done very easily by using this method. This is a Ventrain. This is a newer technique where it has a small needle which can be punctured into the neck below the stenotic lesion, and the anesthetist can ventilate easily for around 15 minutes or so, and you can work upon the stenotic lesion. It's like a jet venturi, but a very small, very portable, and very economical thing to use in our centers. One step ahead, we have this extracorporeal membranous oxygenation or ECMO. This is only available at higher centers, but we can do a lot of distal airway conditions with this, like distal severe tracheal stenosis or slide tracheoplasty. Now, with these advent of newer tubes, which have a 4.4 millimeter diameters, we can do a lot of airway procedures even with intubation, which makes it more safer. And the anesthetists are also very comfortable using these type of tubes. Then we move on to, can we do something to prevent these lesions? Yes, we have reached that stage where we have these endotracheal tubes coming up which are coated with dexamethasone. There are studies which prove that when such kind of tubes are used for a longer duration of time, this can actually prevent stenosis from happening, and this will soon come into the market. Our anesthetists and intensivists are also being trained now that after extubation, if you have stridor, instead of re-intubating, during the second re-intubation, you can apply Kinacort or a triamcinolone oral ointment over the tracheostomy instead of a jelly and intubate. This will act locally on the granulations that are happening in the tracheal region, and it will prevent stenosis. In pediatrics, we are also using these syringes, small syringes filled with Kinacort or triamcinolone. After tracheostomies, if we don't see why the airway was injured, how it was injured, we'll end up in a stenosis. To prevent that, we can use this small ear cannula and inject the suprastomal area. These cases have been done regularly at our centers, and we see that the incidence of stenosis in these children is now reducing in trend. So this is something that can be done very easily after a tracheostomy for adult as well as children. Then we also get cases of incipient tracheal stenosis, which are amenable to endoscopic treatment. Incipient means they are not very well formed scar tissues, but still at the stage of granulations or thin fibrous bands, which present after 4 to 6 weeks of extubation. In these cases, tracheostomy is not indicated even if it is a grade 3 stenosis. I'll show you some examples. Also, we can use a mobile airway card for these patients because these can be dealt with endoscopically. We should size the airway appropriately by using this card, which is available on Apple as well as Android mobiles. You can download it. It will give you size of the balloon which can be used, bronchoscope that can be used, appropriate size endotracheal tube that should be used. Age appropriate things are given in this card. Then endoscopically, what we can do is initially we used to dilate less often. Now it's said that if we dilate tracheal stenosis more often, every few weeks, up to 8 times, then it will give better results. And injection Kinalog can be injected intralesionally to give better results. Certain tracheal stents are coming up. Now we are using these new tracheal silicone stents made of the same material as the T-tubes, but they are beveled at both ends, can be inserted endoscopically as well as by open procedure. Instead of a tracheostomy, we would recommend this to be used. This is our own design and developed in Mumbai. I'll give an example. This is a male patient, has been operated twice and still has this residual lesion below the cricoid with a thick fibrous ring, but it's a short segment. So repeating these dilatations wouldn't make sense. Instead, what we've done here is we've made cold cut Mercedes-Benz incision over the airway, dilated it sufficiently once. If we leave this unstented, this will re-stenose again. So the next step in this case would be putting an endoscopic stent like this. One surgeon introduces the stent in endoscopically, while the another surgeon would pass 2 needles through the neck and hold a Prolene loop and pass it through the thread. And this is how we fix this endoscopically. These 2 threads are brought out and tied. You will see this one single thread holding the stent inside. Now this stent is left for 6 weeks to 3 months. And then when the stent is removed, this is how the airway looks like. So the cords are mobile and this is a very well mucosalized airway, good lumen now. So these patients, we are trying to avoid tracheostomies altogether by putting in these endoscopic stents. Now we have these novel Dumont stents marketed by Novotech company. It of course needs a rigid bronchoscope with introducer, but these can be placed in the distal trachea, proximal trachea, or even at the level of carina. The pulmonologists are also now getting trained in these kind of procedures. So these stents have these struts over it, which avoids slipping down into the airway. There are some self-expandable stents which can be introduced using a flexible scope rather than a rigid scope, and they are available in variety of materials, but the metal ones are avoided. They are only for terminally ill malignant cases. Now these are biodegradable ones, beautiful stents which can be introduced by rigid. Now they are also coming up with the flexible version in children as well as adults. So you can pass it endoscopically, dilate the airway, and then place it and expand it. It automatically degrades by 12 to 15 weeks, and by then the stenotic lesion would have healed on its own. So these are all the examples and case reports where these stents are working very well for both adults and pediatrics. Next thing that has come up is drug-eluted stents, or like we have used those in cardiac stents. There are drug-eluted balloons which use tacrolimus or sirolimus and showing good results. Now, in open procedures, we've traditionally treated these tracheal stenotic lesions with tracheal resections and anastomosis, but not every patient is amenable to these procedures. So I'll show you this case where a young female who has been who was intubated for a long period of time has come up with significant stridor and a very long segment stenotic lesion, which cannot be resected. This cannot be dilated because the dilators will also not give good results in this because it's a long segment. So the next option that we chose was opening the trachea in midline and doing a tracheoplasty, resecting all the scar tissue from inside the trachea, putting this plain silicone stent that I showed endoscopically, and this anterior boat-shaped defect is then closed with tibial periosteum. Now, tibial periosteum has osteogenic properties. When it is left in situ for about a year or so, it ossifies, and when the stent is removed endoscopically, it gives beautiful hardening of the anterior tracheal wall. So this is how the stent looks like after placement. These are the two threads. You just have to cut those threads and remove the stent, and you'll see the result. This is how the stent is removed. We've done 14 such cases, and these are our results. Almost 70% of these patients are showing good results, and we are thinking that probably this is the way where all the stridor patients whom we are recommending tracheostomies should initially be tried with a tracheal stent. If it fails to give good results, then a tracheostomy can be recommended. So this is the way forward. Now, a slide tracheoplasty is a technique which was used traditionally to treat complete tracheal rings in congenital cases. But now, slide tracheoplasty is also being recommended for long segment tracheal stenosis where you can't resect, or a re-resected patient who recurs again, and even in cases of tracheoesophageal fistulas where slide tracheoplasties can be used. The way forward is tracheal transplants, where we know that we need three components: the cartilaginous support, the vascularity, and the mucociliary action. So the best results for a tracheal transplant would be an allo transplant from a brain dead matched donor. So we have developed a tracheal team at Global Hospital with the team of plastic surgeons, and we are trying to get these. We have try to do cadaver dissections and get these models, and we transplant and do anastomosis, vascular, neurological, nerve transplant, as well as the tracheal transplant all together. And this for this, all the government permissions are in place, and this is how we see the future for all these patients who have a long segment tracheal narrowing. Something that we are also waiting and not shown results so far is 3D printed scaffolds for trachea and stem cell transplants, which everyone is trying, but in India we have not seen results with that as yet. So to conclude, we should master all the old techniques like endoscopic procedures, resections, but we should also embrace the new ones, and then for each patient select the most optimum one. Thank you so much, everyone, for your patient listening. I'm happy to answer any questions if at all.
I think there are no questions. Amazing work, Dr. Anju. Uh, uh, this field of specialization that you have chosen is very unusual. I would like to ask you: is it for the our young audiences? Is it because of the rarity of patients that we get? And can you tell the audience about the scope of this field of specialization that you have chosen?
So to begin with, when I started in 2014, there were actually very limited number of patients coming in. Frankly, I did only 6 surgeries in the first whole year. And I was thinking whether I also will have some scope ahead in the future or not. But as the field is developing, people are realizing that these patients are coming up as the ICUs are becoming better. Patients are surviving these post-intubation phases, and then now they are showing up with stridor and all. So there is a lot of things that are building up. Endoscopically speaking, everyone has the endoscope. Now people have access to the balloons. Anesthetists are also getting trained. So my anesthetist is a trained anesthetist in difficult airway anesthesia. So now we can form these teams at a very young age with our anesthetist, and there is a lot of newer things happening in our field, which I can say. But yes, as I see Sunita ma'am saying about allergies and for voice, airway is going to require a lot more dedication, a lot more commitment, because it's an emergency field. So as a female, if I have to balance everything out, I would say that you choose it properly. If you have your heart and soul into it, this branch has amazing future to offer, but you should have complete dedication towards it. This is not something that you can do along with your general ENT practice. It requires a lot of focus and a lot of sacrifices as a female, I would say. Because it's the Women's Day, I would focus on that as well.
True, true. That's true. Amazing work and excellent presentation, Dr. Anju. Thank you very much for accepting our invite. Now we can move over to our last speaker for the day, Dr. Shweta. Janvi, can you introduce Dr. Shweta, please?
Yes, thank you. I would like to introduce Dr. Shweta Patna. She's a professor at RGMC Thane Hospital. She's done her MS ENT from JJ Hospital. She's completed her skull-based endoscopic fellowship under Dr. Ricardo, USA, director at TN Medicity Hospital, Thane. She started a cochlear implant program at 1010 Medicity, Thane. She's published several national and international papers. I'm really sorry for the wrong pronunciation. Welcome, ma'am.
Hello, am I audible?
Yes, ma'am, you're audible, but we can't see your screen, ma'am.
Just a minute.
Sure.
Can you see my screen right now?
Yes, yes, ma'am, perfectly.
Yeah.
Ma'am, if you can on your camera, ma'am.
Yeah. Hello.
You can go on, Shweta. Your screen is visible.
My screen is visible, right? Yeah.
Yes, yes, yes.
So now today's topic of presentation on this Women's Day is navigating the challenges and exploring barriers and how to launch your own cochlear implant program. So today I would be highlighting mainly on the practical aspects of going through a cochlear implant program, how to start about, because many of them have hesitations in the beginning. So what I went through as a new cochlear implant surgeon, what were the challenges, and then how I overcame it. So what are the basic challenges in the cochlear implant program? First of all is the financial burden, lack of awareness among parents and the masses, late delay in identification of hearing loss, lack of mentorship to aspiring surgeons, issues with availability of rehabilitation, and lack of trained manpower or delays due to government policies and approvals. So basically, the most important thing is that financial burden. The cochlear implant, it costs so much that making these funds available becomes a task. And also these patients are mostly from a lower socioeconomic background. So definitely arranging this humongous amount of sum becomes difficult. Also because of lack of awareness. In our society, as much sensitivity is given to blindness, that much is not given to hearing loss. A child who is born deaf is thought that it is his fate, and then that child is segregated from society and he has to live an isolated life. That is one of the reasons, lack of awareness. Next is because this technology is not available to remote areas, and also there is resistance from traditional practices like adoption to sign languages, cultural beliefs. So this also plays a hindrance. So how to break the ice and how to go about going forward with this? To start with is newborn screening with autoacoustic emissions. So we should have a robust newborn screening system with us, and that is possible only when you be hand in glove with your pediatrician as well as a gynecologist. So the first thing to do is whenever the baby is discharged from the hospital, a mandatory neonatal screening program should be done. So when the child is being discharged from the hospital, during this time, we need to do autoacoustic emission. If it comes to refer, then we need to repeat it again after 1 month's time. And it again comes to refer, then we do a BERA testing. Also, tapping these children at a younger age helps you to become more robust in your training and more robust in taking your program forward, because it definitely gives you that much time to arrange for funds, and better you do it at a younger age, more better are the results. So creating awareness is one of the things. And how do we create awareness is by social media. In today's world, social media is one form in which awareness can be created that yes, these deaf and dumb children can be rehabilitated back and they can be brought back to the society. And also television, newspapers, all these can be helped to create awareness. The most important thing is how to acquire this financial support and sustainability. And that is through, this is the most important thing. If we breach this particular part, then we are through. So make use of all your contacts, use all your connections. Your old well-to-do patients can help. Corporate social fundings can help. Many government schemes are there to help us. Also, our banks also finance it. So we can obtain finances from these particular sources. The most important thing is going back to school. That means however mastectomies we might have done during our daily practice, but when it comes to doing your implant, you need to go back, do as many dissections as possible. And also because the anatomy here is different many a times, and also we need to deal with pediatric patients as less than 1 year, 2 year old. So definitely going back to school, getting your concepts back again, going back to what is the recent concept and what are the candidacies, going or staying updated with it is very important. So dissection labs and practice, this will help us to overcome the first resistance. Then the next thing very important is dedicated mentor-mentee program. We should first sort for a mentor who not only helps you with your initial few cases, but also takes you or sails you through any difficulties we encounter. Because as we all know, cochlear implants are not full of surprises. You may come across a gusher anytime. It could be an anomalous cochlear. Various times there are confusions. Where is the round window? So during all these times, you definitely have to have a dedicated mentor to whom you can go back and discuss your doubts and clear out. So going back to CMEs and discussions, so as many we attend as many workshops will help us to be updated with this technology, because it is a evolving branch. There have been so many modifications in it over the period of time. So starting with your just for example, the candidacy. Initially, it was 2 years, then it was brought to 1 year, and then as low to 9 months of age. The most important thing is a multidisciplinary team approach. So when we have this MDT approach, that means you have to be staying connected with the pediatricians, with the gynecologist, your audiologist, speech therapist, everybody. The next is focusing on adult cochlear implant. So nowadays, nobody wants to retire early. If the age of retirement is getting pushed, so everybody wants a very good quality of life till the end. We have many patients who come to the OPD who are old enough, who have got a bilateral sensory neural hearing loss and are on hearing aids, but they do not work well for them. So definitely this option of cochlear implant can be given to these patients, and therefore we can extend our help, and you can apply cochlear implant and they can be brought back. So thank you very much.
That was
thank you so much,
such
ma'am. Ma'am, please take over, please.
Yeah, thank you, Shweta. That was such an informative session for the young surgeon wishing to pursue cochlear implant practices. It must really be a very satisfying experience to give hearing to a newborn the first time. And that was really an excellent presentation. I would like to tell everyone who's attending that our attendees list for today's program have not wavered. So definitely we had a good choice of speakers and lectures going on here today. I would thereby like to thank all the speakers who have accepted our invitation to attend and to give lectures for today's program. I would like to thank our audience to be patient and be with us till the very end. Thank you very much, everyone, and a happy Women's Day to all of you. With this, I think we will end our program.
Thank you.
Thank you.
Thank you.
Thank you, everyone. And happy
Thank you,
Women's Day.
everyone. Happy Women's Day, everyone.
Thank you, ma'am. Happy Women's Day to everyone.
Same to you.
Actually, madam, we can stop the session, ma'am.